Welcome to InCast. Enjoy Health Education's podcast for dedicated healthcare professionals, educators, and administrators who are passionate about making a difference, encouraging healthy outcomes, and finding innovative ways to engage and empower new families and staff. Here's your host, Debbie Young. She's been a childbirth educator and doula for almost 30 years and came to Enjoy based on her love for educating families.
When parents are transferred from standard pregnancy care to a maternal-fetal medicine MFM specialist, it can be an emotionally charged and disorienting experience. They may feel overwhelmed, fearful, or even like they failed somehow. Finding equilibrium in this transition is essential, not just for their emotional health, but also to help them remain engaged and empowered in the pregnancy journey. Today, we'll talk about practical, compassionate strategies to support parents in this process. Our guest today is Dr. Lexi Hill, a well-known MFM who works both with parents and other professionals to make sure parents get the best care on their journey to birth, even if it's not what they planned. There is a missing piece between the patient-physician relationship that needs mending, and a key component of this is empowering patients to advocate for themselves. My goal is to help improve self-advocacy for physicians as well as the patients for which they provide care and guidance. Ultimately, I want to leave a lasting positive impact on the lives of my clients who will do the same for their families, friends, and or other patients. So, Lexi, is there anything else you want to tell us about yourself before we get started?
Well, I live in Phoenix, Arizona right now, and I'm from Texas originally, and I used to actually live in Costa Rica and in Spain for a little bit of time. So that's something kind of fun. A lot of people don't know about me. I did study abroad because I studied Spanish in college. And so that was something kind of fun that I like to do. And I'm looking forward to traveling more sometime soon. I haven't traveled as much recently, but that's something kind of fun. And I come from a very, very small town in Texas. So I think when people are like, oh, you live in the city of Phoenix, I'm like, yeah, but I'm from population 1,200 or so. Yeah. It's kind of fun little facts.
All right. So when we think about parents being transferred from standard care to a maternal-fetal medicine specialist, what's the most common reason that happens?
I like to kind of branch it out into a couple of things. Oftentimes, it can be, number one, something that was pre-existing prior to the pregnancy. Diabetes, a thyroid issue, sickle cell disease, so a maternal issue that was present prior to becoming pregnant. Or it could be something that the mom develops inside of the pregnancy that makes her high risk. And in the third place, so that's the second place. And in the third place, I always think about it like the passenger. This could be the placenta or the fetus, that something is going on with the placenta or the fetus. So any of those things could make someone high risk.
Okay. So it's not like one common thing. It's a bunch of different things that we're looking at.
A bunch of different things. There are some common threads that we see: diabetes, high blood pressure, hypothyroidism. Those are probably the three most common medical conditions that I deal with and manage as a maternal-fetal medicine specialist. And then as far as things that we deal with that are more with the fetus and the placenta previa would be a big one. And then for the fetus, structural or chromosomal abnormalities. So kind of bunch those together. Those would be the most common things that I would say that I encounter on a day-to-day basis.
Okay, good to know. And I know you had to be an OB before you became a maternal-fetal medicine person. What does that journey look like?
Yeah. So it's after college, it's 4 years of medical school, and then you apply to the residency for OBGYN, and that's another 4 years. Then you apply to what's called a fellowship, and that's another 3 years of training in maternal fetal medicine. And that training takes the obstetrical part and really focuses on the medicine within the obstetrical world. So I like to tell people it's almost like internal medicine for pregnant people, because really, I loved internal medicine and I almost went down that road, and very late in the game changed to OBGYN because I kind of learned what maternal fetal medicine was. And I didn't really know that you could do really internal medicine within the obstetrical world. And that's exactly what MFM is. So it gives you those 3 extra years after OBGYN residency of the expertise of maternal conditions, fetal conditions, sometimes fetal surgery if you go that route, and then really working with understanding ultrasound a lot more, which some OBGYN programs do a good job at training us in OBGYN and training us in ultrasound. And some you don't do as much ultrasound, you do more surgery and more deliveries and things like that. So I was in a very heavy program for doing deliveries and not as heavy of a program for ultrasound. So fellowship for me was the time where I really had to learn my ultrasound skills.
So you have a lot more skills than the average OB, and you work with high risk people. So that makes total sense that you have that extra skill.
Yeah. And people sometimes think that MFMs do a lot of deliveries. And in all honesty, the majority of MFMs are doing more ultrasound, sometimes doing deliveries, but do a lot more maybe ultrasounds and procedures and consultations than they really do delivering babies.
So if you were my MFM and it came time for me to give birth, would my OB be the delivering doctor or would you be the delivering doctor?
Yeah, that's a great question. And the answer to that is it depends. So there are places, and since I do telemedicine and work across the US, the really cool thing is seeing the differences in the different communities. And some of this has been guided toward or guided by rather insurance in the way that they do reimbursements. And some of it is maybe just how the tides are turning. Most of the time, if an OBGYN sends you to a maternal fetal medicine specialist for a consultation, the OBGYN would continue your care, and the MFM, such as myself, would kind of be riding alongside, if you will, and guiding the ship a little bit, making suggestions, but your OBGYN is still driving that ship, still the captain, and would be doing the delivery. In rare cases, there are times where an OBGYN will need to transfer a patient fully to a maternal fetal medicine specialist because that pregnancy requires so many extra steps, maybe. And that could be the location of the delivery, or if it's something very rare and specific that really needs the maternal fetal medicine physician to do the delivery. So those are kind of the 2 different ways. And then there are some hybrid-esque models where maternal fetal medicine specialists still love doing deliveries and still do them often. And they actually have a practice where they can do consultative or total OB care. So, I mean, when I say it depends, it really depends. There's a big variability within that on the community you're in, insurance issues, and just kind of how those places have practiced.
Okay, so it's going to be dependent not on the woman's diagnosis as much as what is offered by the different medical providers in her area.
Correct. And a lot of OBs are comfortable with A, B, and C, but not D, E, and F. So some places, some OBGYNs manage all of their diabetics because they're like, yeah, we're comfortable with diabetes. We don't need anybody else to manage most of them. Some of them are like, well, we'll keep a gestational diabetic. But if they have type 1 or type 2 diabetes, we would send them to maternal fetal medicine. So yeah, each diagnosis carries a different level of a comfort for the OBGYN, which then can sometimes help to decide if they keep them in their practice for the delivery or possibly transfer them somewhere else.
And a last thought on that line, my hospital has midwifery delivery also. And I know that if they do have a person who gets gestational diabetes, she's going to be passed on. You would accept clients from a midwife too.
Yeah, of course. And every state's different with the certain laws they have for midwifery and things like that. States I've worked in have been very easy to work with midwives and had a fantastic working relationship with those on what they're comfortable with and what they'd like to kind of have either the OB/GYN if they're working in a group practice with that or an MFM help with. Yeah.
Okay. All right. Cool. So let's talk about how, if somebody is going in one direction and then they need to switch paths, I think we all kind of have an idea of our perfect birth the moment we get pregnant, right? We have this stellar picture of what's going to happen. And then all of a sudden, midway through, then we're not going to have that picture anymore. We have to change, go around the corner and change ideas. And I wonder about the parents' emotional responses and how an MFM can help acknowledge and normalize what's going on. They might be fearful, or they might be grieving their perfect birth or what they thought was their perfect birth. What do you do in that?
Yeah. So pretty much most all of my days are consults with stuff just like this, right? And I would say over half of the people have a birth plan in mind. And it does rock their world to hear something different. So I always start with an introduction of who I am and what I do so that they understand that I'm a little bit different from their OB provider and why I'm a little bit different. And I always start a consultation with, this is why your provider sent you here. Is that what you're anticipating to talk about today? So that
Or
they
even
understand.
realize, right?
Right, exactly, exactly. And so we always start the conversation with clarity, right? Is this what you understand or you are under the understanding of that we're talking about today? And then once they're like, yes, this is what I thought we were talking about today, I try to do my best to counsel regarding specifically that. And always at the end, talking about two main things. Number one, mode of delivery. So, this diagnosis, let's say growth restriction, this diagnosis does not mean you have to have a cesarean. And then, second thing is the gestational age of the delivery. And that can be confusing because when we say your due date, I think people always assume that you're going to deliver on your due date. And only, I think it's like 5% of people actually deliver on their due date, right? Very
Something
low
like that.
percent. Yeah. And so then I let them know if it's something that warrants an early delivery, that can shake them, right? And so when I let them know mode of delivery, if there's a cesarean recommended or not, and then gestational age for delivery, I kind of take them through why. Because if we're recommending an earlier delivery, if I talk about risk benefits, we love for everyone to have a term vaginal birth. That's ideal for everyone. And that's oftentimes what people have in their mind. So when I come in with that news, I say the reason we're recommending delivery be 2 weeks early is because, and fill in the blank. If baby stays in too long, the risk of stillbirth increases. And we don't want you to get to the almost the end of the goal line. You're right about to cross and we experience something so concerning and devastating like a stillbirth. And having that expectation and understanding of why it's recommended. So many times physicians will say, oh, baby's growth restricted, go deliver at 38 weeks to 39 weeks, have a good day. And it's like, but wait, you need to address all the reasons why. And almost always when someone understands that if we keep the fetus in there too long, we could run the risk of a fetal death, a stillbirth. They're like, okay, I understand the reason for a delivery, which means an induction possibly, when I was hoping for spontaneous labor to happen.
But if you answer their questions, their path seems straighter and not as worrisome and concerned. If they had questions about what you're offering, do they have any choices left, or they don't have any choices left?
They always have choices. I mean, in one of the best examples is growth restriction. It's one that we see in my practice or in the practices I cover very frequently. And that's always one of the question, why? And I've had patients that have declined. They're very understanding of the risk of stillbirth, the risk of having to go to the neonatal ICU, things along those lines. And they're like, listen, I understand these things, but I feel like my baby's just small. And in those cases, we pivot, right? And so I like to say, this is what's recommended for safety for you and safety for baby. It's your body, your choice. If you decide you don't want to do these things, let's figure out a safe way to continue to follow you and monitor your baby. And so in those cases, we would kind of give a guidance of, okay, if 38 weeks for delivery doesn't settle well with you after you've been counseled and you understand the risks, what the gestational age would you be comfortable with? And if we're going to try to get you to that, let's figure out what we do between now and then to make sure that you and baby are safe. Maybe we up the monitoring. Maybe we see you twice a week instead of once a week. So making them feel comfortable that if they make that choice for themselves, we're still going to support them. We just need to maybe up our game in monitoring.
Okay. And I want you for my MFM if I ever would need one, because I know other people who have been told, not in such words, but it's my way or the highway.
Mhm.
and they feel very defensive about their choices. So it's in the class that I teach, I always talk about asking great questions to make great
Mhm.
decisions. And hopefully the doctor can see that these people are maybe feeling um, depressed or scared or like they've done something and it's their fault.
Mhm.
And, being able to have conversations, like you said, would make everything so much better.
Yeah, and that's part of when I started trying to get more information out through social media, through a YouTube channel, through different facets, is exactly what you're saying, is that advocacy and knowing that you have the knowledge behind you, but then developing the skill to ask the question. So I, I always suggest that people should, keep notes in their phone or bring a piece of paper to a consult, because it's more efficient. And sometimes you forget when you walk into the doctor's office, and then you leave and you're like, oh, I had all these questions and I forgot. So I make these little handouts. I call them advocacy assistants. So for different high risk pregnancy topics, like hypertension, like advanced maternal age, they're questions to ask, specific questions from my MFM brain to a patient who's going through that kind of thing, so that they can ask all those questions along the way. And even one for low risk patients, like, here are the basic things that you should get. And I don't think, and someone said to me, and it's just a common saying, we don't know what we don't know, right? So
Sure.
if you don't ask about Down syndrome screening, maybe your doctor assumes you're supposed to ask, which is weird. They should offer it to you. But I've encountered people who have never been offered Down syndrome screening in a pregnancy, or carrier screening for autosomal recessive disorders. That should be offered to everyone, but sometimes it doesn't happen. So if we can educate the patients to come in armed with questions, I think it's great.
Because a conversation and building up trust
Yeah,
is going to make their experience so much better.
absolutely.
Talking about building up trust, do you ever send them out to ACOG or SMFM materials that
Yeah.
if you want more than our conversation, here's where you can go to get more information?
I do. And a lot of those, they have wonderful pamphlets that are patient centered as opposed to physician centered, and tons of
Mhm.
great resources. Those are the two main places I send them. And then through those sites, like for medications, SMFM has a beautiful patient link on their site where you can go as a patient and look up any medication you're on. I think it's mother to baby, right? Have you seen that before? Mother to
I
baby?
haven't. I will be looking it up after our.
Yeah. Because when I do a consult for medication exposure, which, given the world right now and all the talk about various medications, over the counter or prescription, there are a lot of questions and fears of, I'm pregnant, what can I do now regarding the medicines that I have been taking or that someone told me was okay to take? I pull up a thing called ReproTox, and reprotox.org, you have to have a login and pay money to get all this information. And it's up to date data on human and animal research. And I pull it up during a consult and I go through it with the patients. One of the beautiful things about telehealth too is that I can have them on this camera, and I can, pull up on my iPad over here and share it with them, and I can send it to them through their portal if they'd like. A lot of that is hefty data though, right? And it's very scientific, and a lot of it's animal data, and it's toxic doses that they use on animals for some of this stuff. So it's hard to compare apples to apples with that. But I give them that and offer them. And I say, if you want more information too, Mother to Baby is this great place. And I give them the SMFM site to go to, because the one thing I can't do is physically give them information on the telehealth visit. But some patients are in a doctor's office, and I talk to the staff and I have printouts ahead of time. So any patient I'm seeing for the first time almost always leaves with a handout that has a picture of aspirin, iron, and a prenatal vitamin. And not all of them need the aspirin, but every pregnant individual, unless they have an allergy or an issue, is recommended truly to take a prenatal vitamin and a low dose iron tablet. And that's a new recommendation from ACOG within the last few years. But it
Wow.
takes like 10 to 15 years for that information to really, truly make change and resonate. So that's the way I try to do it. But if they're on the camera like this, and maybe they're in their home or they're in their car in between whatever they're doing for their job, right? I can hold it up to the screen and they can take a screenshot. So, and I,
Nice.
I learned just yesterday, and this is so true. I had a patient that needed to be on, she had very bad iron deficiency anemia, and she had a reaction to some IV iron. And so she's going to work on getting a different type of iron and do more maybe of the pre-treatment and stuff like that. But she didn't know what foods were high in iron. And so I have a handout and a video on that. And so it's really hard sometimes to get the information to people, but I had a coffee mug made with my QR code on it. And I held it up and it worked. So she could scan it, hit the YouTube button right there, and go straight to the list of all the videos so that she could watch it at home with her significant other. And when they go grocery shopping, they can work on getting foods higher in iron. Right?
What a great idea.
I know, right? I was like, I know. I didn't really know if the QR code thing would work, because that's one of my things is like, man, what if they don't have it printed out? And how are they going to get the QR code? So I'm so glad I found out that worked. I can still drink my coffee and or water or whatever and have a QR code at my fingertips.
Well, and I think if we can help women feel like they have a sense of control,
Yes.
you can give them a list of good foods, right? You
Yep.
can encourage them to rest or exercise or continue with their birth plan with you or their caregiver, right? All of those things can really encourage a sense of self-control, take away some of the anxiety. We can never take away all the anxiety.
Yeah.
But do you ever suggest that people keep a journal of their progress and bring that with them so they can discuss emotions and decisions and bring it all to the appointment?
Yeah, I am all about, I love journaling. I probably need to get back into it more. I think it's very helpful because I always let people know it's good to have a mental health provider in your corner. And I like to say in your front pocket, not your back pocket. And to have like a third party person involved during a pregnancy and after, because the hormonal changes during a pregnancy can be a roller coaster, and after, holy guacamole, right? Like those can be legit. So anyone who has any history of anxiety or depression, I strongly, strongly ask at the first visit I have with them, even if the referral is maybe, let's say, for the baby, there was echogenic bowel noted, and we're talking about the fetus. If I see in the history anxiety and depression, or generally in most people, I just ask, do you have a mental health provider? And if they say no, I usually just ask them, look on the back of your insurance card. There's usually a phone number. Deal with them now by being on the phone for 2 or 3 hours if you have to, right? To get someone so that if you need them during the pregnancy or after, they're readily available to you. And journaling or even saying it out loud or whatever people can do to have a place to get it out as opposed to not saying it to anyone or letting it out is a very, very nice place to be. And oftentimes doing that, it gets them a nice concise list for when they do come to the doctor, right? Where they've worked through the questions or they've written things down, done some research maybe, and now they've come back with a clear question. So I think it's helpful. Yeah.
And then putting the answers that they got there, they can always go back and refer to it. So I think it is a way to make that a better thing. And I think that shared decision making between the doctor and the client it should have always been the way, but I think it is the way of the future. Would you agree with that?
I agree. And, I always try to tell people we as providers have been patients. We are patients, and when I first got my diagnosis of a non-ischemic cardiomyopathy when I was 18 years old, I was by myself in the doctor's office, and legitimately, this is how the consultation went. Your ejection fraction is low, which means the squeeze of my heart wasn't so great. I'm going to put you on a medicine. Come back in 3 months. If it's not better, we'll put you on the transplant list. And he was out the door. And I was like, I'm in college. I'm about to take finals. And I was like, wait, what? And I was 18, and taking like 20 hours in college on scholarship, trying to wrap my head around this. And I'm like, I just used to have fainting spells, they called them. And that's all, that was my biggest symptom, my only symptom, but they were concerning to me, but no one ever really thought they were anything. So that always stuck with me. And I remember I always was interested in going into the field of medicine. That day solidified it for me because I was like, you know what? I'm pretty sure I can learn what he's learned. I can go through medical school. I can do that. And if I do, I'm going to be so much nicer to my patients. I'm going to communicate better with them, and I'm going to listen to them. I mean, there was just no reason for that to have happened. But I will say it did put me toward a really very, very structured and I was so excited about this drive that I had to go straight into medicine. And I knew I didn't take any time off. Like I skipped a year in high school to get to college. And then I worked for a year as a medical assistant. Like everything I did had an intention to it to get me to be a doctor so that I could be like, hopefully, a better communicator and a better doctor. Maybe not smarter by any means, but just showing patients that doctors care. Because I think most of them do. They may not show it appropriately, but most of them do.
And I think that the caring shows that the person you're caring for is not just a robot or not just it's not like you're treating a green bean, you're treating a person.
Yeah,
so
exactly.
All right. Well, do you ever talk to parents about building a community of support around them as they're going through what they may feel is daunting?
Yeah, all the time. And a lot of the things that I deal with, some are common, more like high blood pressure, diabetes. Oftentimes it's something more rare, a genetic chromosomal issue with a fetus. And for that, since they are more rare conditions, there are a lot of different places I try to encourage them to go if that's what they would like to do, to find a place to talk to other parents about this. Say that a cleft lip or a cleft palate is noted. It's nice to talk to a parent who has gone through already the birth of a child with maybe that type of a birth defect or that type of a chromosomal defect and found the right pediatrician or the right dentist for someone who had maybe a cleft lip or palate. And those groups are across the US, and because of social media now, the ability to reach people is a little bit easier. And even internationally, it's very nice to be able to say, I mean, I've had contacts and people in other countries where sometimes we reach out to get people some help and encouragement. And it's very nice to have the ability to give people these resources. So all the time, I feel like definitely giving them as much as I can for resources, whether it is a support group or even something online where they can then find a group that they feel like they kind of jive with.
Right, right. And I know that you're not only talking with people in your own area, but I think if an MFM were like from my hospital and he knew of a physical group, that would also be a nice thing to be able to mention.
Absolutely.
So, what's your thoughts of helping the family maintain the pregnancy joy that they started out with? I mean, they kind of feel like maybe they hit this bump in the road, but how can we help them get that joy back?
Yeah, I like pictures. People like pictures. A lot of the places I work will either print out a picture for patients if they can get a good one, and we try really, really hard to get those good pictures. They can also go and pay for pictures somewhere else, right? If they don't want to go to the clinic or a place, where they're having medical care and have ultrasound done, if that's something that helps to bring them joy. The other thing too is, as you mentioned, providing resources. I do think that resources are helpful, particularly in cases where it sounds big and scary and it's not going to be as bad later down the road. That's really, really helpful too. And a lot of the pictures too that we have in certain places can be uploaded to a portal or texted to a patient. And so they can sometimes see those and have those if they would like to do whatever whatever they want to with those. And I will say 3D images are great to get whenever we see those cute views, the cheeks that we can see sometimes, the little toes. Sometimes babies will stick out their tongue or they'll smile, blow little bubbles, things like that. So 3D imaging is great when we can get it for patients. And I do let patients know there are many, many places that don't have 3D probes. And so if you go somewhere, don't assume that they will have a 3D probe there. And if they do, sometimes the sonographers may not be skilled because it takes a while, a lot of physics to understand the X, Y, and Z planes and render an image that's 3D from a 2D that they're getting on the machine kind of thing. So I think those are things, pictures and support groups. And also the last thing I will say on that too is having continuity. I think it's great to see various providers, especially if another opinion is needed or if the patient requests to see someone else. I always encourage a second opinion on certain things if people just would like other opinions. I think that that's wonderful. It is nice to go in knowing that someone knows your story. So that I think is really, really big. And asking, I think it's important to, when you get that rapport, ask the patient, oh, how did your baby shower go? Do you have pictures you want to, sometimes people share the pictures from their baby shower. So the things that make it feel still like, and I'll say the word normal. I don't like saying that word, but sometimes when people have a high risk pregnancy, they feel like they don't have a normal pregnancy anymore. And so anything to normalize the pregnancy still, to say, the baby shower is a big one. When you hit a certain gestational age, things like that.
Sometimes I wonder if families are so kind of disturbed or upset about this that they have kind of kept it to themselves and they're not maybe sharing their angst or their joy with their loved ones because they're not sure what's going to happen in the future. Do you have any ideas for families around that? Should they keep it to themselves or should they share?
I think that's a personal decision every time. And if they want to let us as the provider know so that we can be supportive of that journey, totally up to them on how they'd like to handle any situation, for sure. And the other thing that may be helpful as the provider in talking to the patient is giving them an update every time. Because even though we may have said at the first visit, our plan is A, B, C, D, they may have only heard a certain percent of that. Studies do show that patients only hear a very small percent of what we tell them, especially after we give them maybe a poor prognosis or bad news. So it's nice to readdress, okay, so remember our plan is you'll come back every week, every other week, and then our delivery timing is 39 weeks. Okay, that sounds good, right? So just revisiting the same thing, I think, each time, and always ending, and I do this with every consult. Do you have any questions about the ultrasound, the plan? And the ultrasound, if there's something else we talked about, the ultrasound, what we talked about today, or the follow-up plan. And most of the time, I'm very happy that patients are like, no, you explained it. Thank you so much. And sometimes it's like, no, I really didn't grasp this. So can we go through this one more time? So I really like beginning a consult a certain way and ending in a certain way so that there's a closed loop communication. And I think that part of that communication with a higher risk pregnancy is, if it's something that's truly of concern that a patient may not be sharing with others, to ask them if there's anything we can do. And if they bring someone to the visit, if they're okay with them, coming into the room. That happens a lot with ultrasound. People bring multiple people and they need to share with us if there's someone that they don't want the information shared with, because you're bringing them to a medical visit.
Mm-hmm. Yeah. Yeah. One or the other, right?
Yeah. Yeah.
So when they feel like they're partners of yours, I'm sure that must make them feel more solid, more trusting. And you had mentioned before that you're encouraging them and establishing rapport, even if you're not actually the one who's delivering the baby. Do you have follow through the pregnancy and even after, or does it kind of stop, or how does that work?
It would depend. So in my prior practice, I would often see them again in another pregnancy, possibly, and they would bring in the prior child after delivery. And I used to have more follow up in the practices I was in when I was more in an office, because people would stop by. And now, since it's remote, I don't really have that as much. And I do tell people there's some places that I've seen patients multiple times and seen them through 3 births remotely. So I do get to see their babies again, which is really, really fun. And sometimes in some of the sites, they will actually stop in and bring their kids and have the nurse who's on site text me, call me, whatever. And then we jump on our like HIPAA compliant portal thing and I get to see the baby. And it's
Oh,
it's
nice.
so much fun. But I very rarely get to actually see them for any follow-up or know how things turned out, which is, that part's not, I mean, I miss that part. I'm not gonna lie. I just, the good thing is that most of these people are with amazing OBGYNs, and they really do. I mean, they most of them are doing the deliveries and they are bonded, to the patient, and they have that really close follow-up. So I'm glad that I can be supportive of them having that relationship with the patient still.
Yeah. Yeah. And again, as a telehealth professional, it's a little bit different than if somebody has their OB here and then the next office over is their MFM. So it's a bit different.
Yeah.
So now can we talk for a minute about trauma-informed communication? Is that something that is just needed for people who are having to switch to an MFM, or is that kind of broad?
I think that's an excellent question and topic. And I think we handle it as best we can. You know, um, it's always in the best interest of patient and provider to ask questions along the way as well. And I think that that is something that really, really helps individuals. And understanding the way I like to say it is I don't like surprises. So I like to tell you what all the possible risks could be so that if they happen, it's not a shock or surprise. And I think one of the examples I think of when you mention this is someone goes in for a third a third cesarean section, right? They've had two, they want a repeat. They're having a scheduled, let's say, cesarean. Anytime we consent people for surgeries such as a cesarean, they sign a piece of paper. And when I was consenting them, I would go through the piece of paper with them, right? Risks of bowel bladder injury, risk of possible hysterectomy, particularly if you're having bleeding and it's to save your life. So I would always go through that with people. And the reason I liked being able to go through it was because there were probably one or two occasions where bleeding happened and a patient needed a hysterectomy to save their life. And looking over the drape and saying, "Hi, Mrs. So-and-so, remember when we talked about that rare possibility that we would have to take your uterus out if bleeding happened? We've encountered some bleeding, and that's what's going to go down now." And it's so nice when a patient's like, I mean, obviously no one wants that to happen, but they're not surprised, is my point. So if we do a good job in truly communicating and counseling, I'm hopeful that those types of things that could cause traumatic issues for anybody would be very diminished.
That's such a good point. And I think that not having a surprise is partly on the patient too, because if you've ever clicked on yes for terms and conditions
Mm-hmm.
for a program or something, we have gotten to the point where, oh, it's a piece of paper I have to sign. Well, okay, I'll just sign it. But actually going through it with you, line by line, so there's questions that you can answer, things like that, is so much better.
Yeah.
Um,
Yeah. And it's great to be able to, I mean, and I just went to a doctor's appointment today. I had to sign 4 different sets of documents, like 20 pages long each. I can't read all of those because you told me to show up 30 minutes early, which I did. It would take me forever to read all of those. And most of those are boilerplate. But again, when you're going through procedural items, those are the ones to me that really it's nice to look through and understanding that if something does happen, you're and it's so hard to be a patient and a provider, right? Because you know both sides of it. I never want anything that's a risk to happen to a patient ever, ever, ever. Can I prevent that fully? No. Can I educate them? Yes. And when I say I can't prevent it fully, I can do all the things to try to make it not happen. I can be well educated, well trained, well versed in if something happens, what I do next. However, there are some things that are not truly preventable that I cannot fix. So when I do see patients, sometimes after a consult, I can see they're a little overwhelmed. And I'm like, my job sometimes is to tell you all the bad things that could happen and counsel you about all the risks. Your job is to understand that they probably won't happen, right? So when we say increased risk, it may be increased by 10%. That means there's a 90% chance possibly this won't happen to you in a way, right? So I always tell them, I just don't want you to be surprised. So here are the things that could happen so that if they happen, number one, you can ask more questions and be prepared. And number two, you're not blindsided by it.
and I think that's really, really important. If you're supporting parents as a professional, um, your listening ear, your calmness, just in our conversation today, the demeanor you present with probably is a good anchor for that transition. So I hope that everybody who has an MFM like you, because I would certainly want you to talk to me in a case where I was unsure. Things were changing so fast. I didn't like my head is spinning. You can calm me down and help me through that.
Thank you. And that means a lot because it's definitely something that I hope when I talk to people that they leave a conversation feeling more calm and more reassured with what they're going through.
Yeah. So we're just about to the end of our time together, but do you have any additional insights you want to share with the listeners?
My big thing would be continue to learn the best way to advocate for yourself and not just reading and getting more information, but taking that information and putting it into very clear, direct questions. So when you go to a provider anytime, that you're armed with some very clear-cut questions and you leave there with some answers. And I think that that's something that's so important, to leave there with some extra knowledge and answers to the questions that you have. So that would be something I would want to leave to the listeners.
Great advice. Thanks for being with us today.
Thank you.
This episode of InCast is complete. Tune in regularly to hear more insightful conversations. And be sure to visit enjoyhealtheducation.com to see how Enjoy can help you inspire families and staff through our diverse childbirth and parenting teaching solutions. Or call us at 1-800-326-2082. The views and opinions expressed in this podcast are those of the guests and do not necessarily reflect the official position of Enjoy or its employees. This podcast is intended for informational and educational purposes only and does not serve as medical advice, a basis for diagnosis, or recommendation of treatment.